Welcome to part 2. Glad to have you back. Let's go ahead and dive in and get started. Can we prevent hernias, diastasis, and pelvic floor issues? This is such a great question, and in some cases we can, in some cases we can't. So with the pelvic floor, we look at trauma during delivery versus improper execution of exercise. What's going on there? So if someone ended up needing an emergency forceps delivery and that caused a avulsion of their levator ani muscle, that will increase their risk of experiencing prolapse and other pelvic floor issues postpartum. So there are things that we just cannot control, okay? Tears that cause scar tissue. So we're going to talk through some of those major things that can happen during delivery and what a pelvic floor PT can do for them and what we can do for them through exercise outside of pelvic floor PT. So when to refer out and what we can do to make their life better. And then we have to look at improper execution. I can't tell you how many times I've gotten a message from someone who is 6 months, 8 months, 10 months postpartum, and they're like, I got prolapse because I did this baby stroller boot camp, or I tried to lift my kid over my head to hand them to somebody over something, or, I did something stupid. Okay, so there are so many times where there are preventable issues and they're not preventing them because they don't know any better. So it's our job to educate them. We've got to get out there. We've got to spread the word. We've got to help these women prevent prolapse by not overloading their pelvic floor the wrong way or doing too much too soon early postpartum. And then we have to look at just correct function, reestablishing correct function and correct strength, because a lot of issues with leaking are just due to how the pelvic floor muscles are working, how they're firing. Are they coordinated with the diaphragm? Is the pelvic floor tight? What's going on there? Okay, so we're going to dive in a lot. There's three separate modules on the pelvic floor. So we are going to be covering the pelvic floor so much in this course and so many details. So we're just going to touch on it here. But I just wanted you to start thinking about what's preventable and what's not, because I think in a lot of ways, we don't recognize all the preventable pelvic floor issues. We wait until it becomes something major to then say, oh, hey, yeah, let's take a look at the pelvic floor now. No, we need to start looking at the pelvic floor first. Diastasis. Are there preventable strategies during pregnancy? We'll talk through a few of those. Does it come down to genetics, hydration, or diet? Maybe a little bit. Postpartum recovery strategies. Those are really important. I've definitely talked to people who have had a 2-finger diastasis, and then they said they went and did some kind of abs class, and then it went to 4 fingers. And they come to see me and their 4 fingers. They're like, it wasn't 4 fingers prior to this class, prior to overloading too much. Okay, so what's safe? What postpartum core recovery strategies should we use, and how do we overload safely to help with fascial healing? Because fascia needs stimulation to heal. All right, if we throw an abdominal binder on and we never let the fascia handle any load in the middle, that's going to prevent long-term healing. We've got to have some stress to heal. Our body's got to know it's an area that it needs to send attention to. It needs some stress. It needs some strain, but it doesn't need too much. And the same thing happens with the pelvic floor when we're thinking about healing prolapse. We need some stress, but not too much. So what is core pressure? Core pressure is going to play such a big role in healing for both of these issues. So core pressure is the amount of intra-abdominal pressure needed to keep your spine safe and healthy. Right? It's important. We do need some intra-abdominal pressure. Too little pressure and your spine will be vulnerable to injury. Too much and you'll likely suffer from hernias, pelvic organ prolapse, or pain from over bracing. One thing I really want you to keep in mind is that pressure can change from minute to minute. So I've definitely seen people where they have no pressure. They kind of hang on things. Nothing's really contracting. There's no pressure. And then all of a sudden they go to try to handle a task or pick their kid up or lift a weight at the gym, and they create entirely too much intra-abdominal pressure. So sometimes we just need to help women figure out how to have moderation and how to control their core and control that pressure so they're not putting too much when they go to handle a task. And then they're not just kind of hanging in things when they stand around for their posture. All right, so self-awareness, so building awareness in this and education really goes a long way for helping them find that perfect middle ground for core pressure. So not too much and not too little. So that perfect amount of pressure helps with healing for the abdominal wall for diastasis and for pelvic floor issues. So the diaphragm, core, which is TAs, internal obliques, and multifidi, and the pelvic floor provides central stability for the spine and pelvis. So think about this as our abdominal pressure canister. They help to create and regulate pressure along with the surrounding muscles. So think of this as a pressure canister. We have to learn how to best regulate and control that pressure. So to inhale and exhale under a load correctly requires eccentric strength. So when we inhale, our diaphragm goes down, our abdominal wall expands. If we're inhaling during, say, a plank or a heavy squat or anything else that is an exercise that requires a little bit of abdominal control and work, we have to have eccentric abdominal strength to allow the abdomen to expand, to have that deep breath while contracting. So eccentric abdominal strength. Now, on a forced exhale, so the diaphragm goes back up, we need to have eccentric diaphragm strength because it's helping to control that exhale. So I will often see cheating strategies in people when they go to exercise. So they might be able to get that great deep breathing 360 pattern when they're at rest, but you wonder why they go to do something and then they have an increase in pelvic floor symptoms, and it often comes back to the inability of their body to load their canister. So they will have cheating strategies. They will breath hold. They will shallow breathe with excessive bracing. So let's say somebody's going to do a plank and you're concerned with what's happening with their pelvic floor. You're concerned with what's happening with their prolapse or their diastasis, and you want to make sure that they are regulating pressure in their core correctly. One thing to do is put them in that plank and then watch for that deep breathing pattern so that they excessively brace and then slip into a shallow breathing pattern, or are they able to maintain that deep breathing pattern with lateral rib expansion, back body, and sides. That takes tremendous amount of strength, all right? And so if they overbrace and go into a shallow breathing pattern, we don't know what's happening with that pelvic floor from an external view from watching them, and we can assume that it's no longer connected with the diaphragm. So remember that nice movement with the pelvic floor? All right, when you don't have that inhale that goes down, we most likely do not have the exhale that comes back up. And with that exhale that comes back up, we get that natural pelvic floor contraction. So let's say you want to do a squat or a deadlift or some other hard exercise, and you exhale on the hard part because you know exhale on the hard part. Well, if the diaphragm is not connected with the pelvic floor, that person could very well bear down on their pelvic floor instead of it getting that natural lift. Okay, so making sure that they can keep a great breathing pattern through a load is incredibly important. So if we don't train someone for challenging situations, how do we expect their body to respond the right way when loaded? I see this so much in the women that I talk to that end up with prolapse well postpartum because they tried to do something hard. I remember one woman, she was 8 months postpartum, C-section, and she was at some event and she had her kid in the stroller and they were trying to lift the stroller over a log. So she was lifting her in, and she's like, right after I picked up the stroller with the kid in it, I immediately felt the prolapse. She's like, I just knew that is what caused it. And I immediately felt it. When it happened, her body was not ready for that load. She bared down on her pelvic floor to increase her strength to be able to lift that stroller. So whether we think it's important to get women strong or not, they need to be strong to handle life, because you never know when you're going to have to do something. And you don't want that something to be the thing that causes prolapse or causes a hernia out of your diastasis, okay? So we want to help teach people how to load correctly under pressure, because I think that's really important for the health of their body later. We want to teach them awesome strategies so they can be unstoppable and their body responds automatically and correctly. So we will be ensuring success. Yay! So reestablish correct function, then progressively overload it. So increase the challenge that you place on their body. When one of these pieces is not functioning correctly, dysfunction is sure to follow. Without stability of the spine and pelvis, the structures above and the structures below will not be in a correct alignment. So think neck, shoulder, scapula, hip pain, and tightness. All right. So when the middle doesn't work correctly, the rest of the body pays. So just keep that in mind. That is why this is all so important. All right, let's hone in just a little bit on the pelvic floor. So one of the questions that I get asked the most is, what's the difference between relaxing for the inhale and bearing down? So many women ask me this question that I wanted to answer it here, so then you guys can answer it with the people that you're seeing that might possibly ask you when you start saying, I want you to give me a nice big inhale, feeling your pelvic floor relax, and they're like, well, am I bearing down? I'm really scared. I have prolapse. And that is where it comes down to trusting your body and trusting the person in front of you. And that's why we need lots of confidence when we're trying to help women with these issues. Okay, so think about your pelvic floor as resting at the ground floor. Okay, so ground floor is normal resting tone for the pelvic floor. When you do a Kegel and you think about purposely contracting your pelvic floor, you lift your pelvic floor up. Think about it as the elevators in a house. Okay, so you're lifting up. When you inhale down to the basement. So I want you to try that for me now. So sitting up, it's easier than standing. So sitting up, I want you to think about a big inhale and feel that inhale push into your basement. So think about the pelvic floor as a balloon. You're gonna let it expand just a little bit. Think about blowing it up like a balloon. Think about the front of your pelvic floor. Think about the back of your pelvic floor. We're gonna talk a lot in the course about preferentially recruiting the front versus the back and how to deal with tightness in the back, because that's more common. And then reestablishing correct function in the front, which is leaking. Okay, so inhale, you're gonna push your pelvic floor down into the basement, getting that little bit of expansion. And then a natural exhale goes to the ground floor. So some people can feel that natural pressure down and natural recoil back up. So this is that give and take of the pelvic floor with the diaphragm all day long. And then when you do a Kegel, you get purposeful up through the levels of the house. Now, what happens when we bear down? Bearing down is like sending your pelvic floor out the basement window. Okay, so I recently gave the analogy of you got to go to the basement because that's where the washer and dryer are. Okay, we've got to go there, and a lot of women don't get a deep breath in because their pelvic floor is tight. So when your pelvic floor is tight, it's very difficult to go from the ground floor to the basement. You're just not getting that great expansion. You're not getting the eccentric load on the pelvic floor. It's just super tight and it's holding there. So when that happens, you don't have correct function and you can't get a great contraction. All right. And when you bear down on the pelvic floor, that's like sending the pelvic floor out the basement window. And when people bear down when they load, that is increasing their risk of prolapse. Okay, so just keep that in mind for normal pelvic floor function. So if you have somebody who's afraid to give you that good inhale, just explain it like this. Just say, hey, we need to go to the basement. All right, you need to trust your pelvic floor. You need to let it do its thing. You need to let go, because one of the main things that I see with people who are new to prolapse is they try to protect it. They try to keep it safe. They're like, my organs are falling out. I need to hold on to them with dear life. And so they end up holding a Kegel, holding some pelvic floor tension all the time because they're so afraid to relax. And it can be a subconscious afraid. They might not even realize they're doing it, but they're just so afraid of making it worse. So they try to help it out. And that in the long run makes it worse, because the tighter you hold your pelvic floor, the more dysfunctional movement happens, because a tight muscle is not a strong, properly moving muscle. So then the more prolapse symptoms they have from it, then the worse they feel, and then the more they want to protect it. So it becomes this bad feedback loop. So getting somebody to really relax, feel that great inhale, is going to really help release their pelvic floor. So hypotonic versus hypertonic. So think about this as hypotonic, decreased pelvic floor tone, and hypertonic as increased pelvic floor tone. Right, so when we're dealing with somebody who has low tone in their pelvic floor, meaning their muscles just kind of don't want to join the party, okay? They don't want to do anything. They just kind of want to hang out and just be flappy. They don't want to work. This is where when somebody says do your Kegels, this is the person that helps, okay? I find this can happen in longer pushing phases. So during a vaginal delivery, the muscles can kind of just get turned off. they're stretched out and expanded for a very long time if you have a long pushing phase, and this can decrease their proper firing. All right, so that is the person that needs Kegels and they need cueing. So they're not necessarily weak. They can be weak, but they're not necessarily always weak. It can just be a connection issue. So sometimes our brain just takes a little vacation, and we need to reestablish the connection with the pelvic floor, reestablish that connection with some breathing, do some Kegels on some exhales, and get that pelvic floor responding and working properly, and then it will naturally get stronger. Okay, so this is what happens with a low tone pelvic floor. Now, if we have a higher tone pelvic floor, this is that person that I'm talking about who wants to protect their prolapse. Maybe they're worried about leaking, so they tighten up a little bit, or maybe they're just a tense, tight person. So think about that person that tends to hold their shoulders up by their ears. Okay, so maybe they're just a gripper. All right, I definitely see this in women who tend to grip their glutes. So if they clench, one side clenching, also associated with SI joint pain. All right, or if they're both sides are clenching, looking at the glutes is a great clue as to what's going on with the pelvic floor. So if they tend to clench their glutes, they almost always clench their pelvic floor as well. So if somebody is tight, they might be hanging out on like the second or third floor even, and they're going to have a difficult time contracting because they're already halfway up. And then they can't get a good inhale down because their pelvic floor doesn't want to relax. And you've got to get that relaxation to get to the basement. Okay, so both low tone and high tone can be weak, but if a person with higher tone starts doing more Kegels, they're going to end up in a world of hurt. And that is the story that I've gotten from. I worked on contracting my pelvic floor, and I just got worse. It increased my pain, it increased my hip pain, it increased my back pain, it increased my pelvic floor tightness. Okay, so with this person, you're going to really want to work on relaxing the pelvic floor, work on working those inhales, and seeing a pelvic floor PT to get some good release if they've got knots in there. So there's all kinds of things we're going to do, and we're going to look at incorporating low tone and high tone and kind of how to tell better cues, and how do we incorporate this in with somebody's programming so that we can help address them directly and specifically. So paradoxical breathing is one of the easiest things that you can fix. I want you to start fixing it on everybody that walks in. All right, so if the diaphragm is not going down for the inhale, it's probably not coming up for a forced exhale. So paradoxical breathing is when their diaphragm basically goes the wrong way. So they inhale and their diaphragm goes up. And I've got I'll include a video in this course for you guys so you can take a look at that, an example of a paradoxical breathing pattern. Okay, so if that's happening, if their diaphragm doesn't go down for the inhale, it's probably not coming up for the exhale. If the diaphragm doesn't come up for the exhale, then that is going to increase pressure down. So think about this with a cough or a sneeze. So if somebody goes to cough, sneeze, or even just exhale hard for exercise, and their diaphragm goes down, that's going to push down on their pelvic floor. That's going to increase their risk for leaks and pelvic floor issues. So it's such a simple thing to retrain to inhale, diaphragm goes down, exhale, diaphragm goes up. And so when we get that exhale, if the diaphragm automatically goes up, that's going to help relieve pressure out of our system instead of creating more pressure. Okay. So I have got a little cue that I really like to look at for this that I want to go through with you guys. I think it's really helpful. But first, let's take a look at the hip. Okay, so why does hip motion matter? And yes, I'm still talking about the pelvic floor here. So if the hip doesn't move correctly in the socket, what controls bones moving? Muscles, right? So if the muscles surrounding the hip are not pulling and contracting like they're supposed to, then that causes pelvic floor issues. So you end up with compensation patterns from the core and pelvic floor. The hip muscles overlap with the pelvic floor muscles. Guys, the obturator internus, obturator externus, piriformis. We're talking about pelvic floor muscles here, but we're talking about hip muscles as well. Okay, so really keep that in mind, that the pelvic floor and the hip are very closely linked. And if you have a disruption in the way the muscles around the hip are firing and you have any type of hip dysfunction, that is more likely to cause pelvic floor dysfunction. So we're going to talk a lot about femoral acetabular motion. And I will break it down. I promise some of these concepts are really hard, but I'm going to make them super simple in the course, and we're going to go over it in lots of detail. So when you have weak external rotators, So think about external rotators as those deep muscles in the hip, like the piriformis, like the obturator, like your glute max. And we have a lack of core strength. That typically causes someone to clench their glutes. So clenching over time causes a loss of internal rotation, range of motion, because the femur gets shoved forward in the socket. All right, so we're going to go over how to tell if the femur is sitting forward in the socket. All right, so a loss of internal rotation causes a loss of external rotation. So a muscle must fully lengthen to be able to contract. So if we can't get the leg to go in all the way, if we can't get length to the glutes and deep rotators, we're not going to be able to get a full contraction. So this forward position in the socket from clenching disrupts the ability for the external rotators to function correctly and get stronger. And we need great external rotators to have a great pelvic floor. So we have to reestablish internal rotation with that posterior glide of the femur to get effective external rotation. So basically, we're going to create some space to roll back and glide forward to be able to execute that external rotation. So this applies to people who have decreased glute strength. So that person that's there going to the gym, they're like, I just still have mom butt. Like, I can't seem to put on glutes no matter how much glute work I do. This is that person. We're going to fix their glutes. We are going to put glute strength on them, and I'm going to show you how to do that. This is pelvic floor dysfunction. I've had so many cool instances where I get somebody's femur sitting correctly in the socket and functioning correctly, and all of a sudden their pelvic floor strength goes through the roof, like doubles in strength, because their pelvic floor muscles are aligned. So think about when things are in a better alignment, they're able to function properly. I got a really cool story from one of the women who just went through the course. She was a pelvic floor PT, and she took this course to learn more exercise ideas, which was awesome. And so she told me this really cool story, because I was talking about this femoral acetabular motion, and we were going through exercises and things to do for it, and she put the femur back in the right place. So she helped to align it from the outside. And then she did an internal exam on her patient. And she was like, my patient's strength went from a 2 to a 4 just from me putting the femur in the right place. How cool is that? So one of the things that I really want to get across is it's not always the pelvic floor's fault. So we might be doing Kegels and doing Kegels and doing Kegels, and we're like, why am I not getting stronger? And we need to look at the hip. Okay, so that was just such a cool story, and I love how she was able to immediately apply that and feel inside and feel the doubling of strength from simply repositioning the femur. Okay, so that was just, it's really cool. It's so cool to see people, like, it literally will turn on their pelvic floor. This applies for people with femoral acetabular impingement, so people that are pinching in the front. So like if you go to do a knee across to the opposite shoulder and you get that pinching, that can be a sign of impingement, and so we're going to help work on fixing that. Piriformis syndrome and SI joint pain, so all of that matters for how the hip is moving in the socket. All right, so stop clenching. All right, so one way is just to bring awareness. So have people stand up, squeeze their glutes, and let them go. All right, so that is a great way. Just have them do it several times during the day to bring awareness, to get them to stop clenching and relax those glutes. So then we can get length to then get a great glute contraction, so we can start building glute strength. So one way I like to do that is by teaching this hip hinge motion, where you'll just have somebody stand away from the wall a little bit and stick their bottom out to touch the wall. Now, a couple of things you'll notice here. I'm not hyperextending my neck, so I'm not looking way up. I'm also not hyperextending my back. So when you hip hinge back, it requires some core control so that you don't hyperextend and cause somebody's back to hurt. So when somebody starts first hip hinging, if they don't have any core support and core control, then they might end up with a sore back because they will hyperextend. So watching for that is really, really good. So make sure the motion comes from the hip and comes from the glutes lengthening, and doesn't initiate by their back arching. So the same thing if you're watching somebody do squats. So make sure you watch for their glutes to lengthen first for any movements that involve the lower body, that involve this glute lengthening pattern, and not see hyperextension in their back first. So one of the things I really see is when they hyperextend first to initiate the motion. That just leaves their back tight, and it tells the glutes they don't have to work as hard. So the glutes are like, well, I don't need to work, the back is working. All right, so we get this pattern of going back and forth in the body where nobody's doing their job again. I just wanted to touch on prolapse before we wrap up this little mini course. In the big course, we're going to go through all the stats for prolapse, what it is, what to do about it, how to, considerations for lifting, and all that good stuff. But for now, I want you to think about what increases the risk of prolapse and what decreases the chances of healing. And then let's take a look at what we can do about it, because this is so important. There are some things we can change and some we can't. Muscle tears during delivery. All right, so especially if someone had a forceps delivery, it's going to really increase their risk of getting prolapse. So if someone had a forceps delivery, this is an important reason why you want to ask a new postpartum woman that comes in to work with you, what kind of delivery did you have? Tell me about it. And if they say, oh, I ended up having to have an emergency forceps delivery, then just put a little note in the back of your mind. You know what? They might have ended up with some muscle tears from that, specifically that levator ani muscle, and that's going to increase their risk of getting prolapse with hard exercise. So that's going to be someone you really want to make sure they are mindful of pressure down on their pelvic floor and they have reestablished great strength, because they are going to be at an increased risk. There are some things that we just can't control. Prolonged pushing phase also increases risk of prolapse. Then we look at the things we can control. Too much pressure. Do they bear down when they handle a load? Do they create too much pressure in their intra-abdominal cavity? That is something we can fix. That is something we can change, and we can completely eliminate that risk. Muscle weakness, that is also something we can change. So we'll go over when to prompt women to do Kegels, when to not prompt them, how many, and all that good stuff. All right, so the takeaway from this is to make sure your client is not bearing down when exercising. So if there's one thing you take away for decreasing the risk of prolapse, please take that away. So let's go ahead and see what we can see on bearing down during exercise, because we can kind of get a little picture from the outside on how much pressure someone is putting on their pelvic floor. So here's a starting shot of her resting posture. All right, so it's important to note the resting posture in the stomach, so you can tell how much body fat they have, what their belly looks like, and then that way you can tell the difference when they're bearing down. So when someone is bearing down, when they go to load, their lower abs will tend to bulge. And so this will give you a little sign that, hey, they're bearing down. So I want you to start noticing that when you watch people work out, when you watch people do exercise. And Instagram is great because for a lot of it, you can really see what's going on in people's bellies. And so a lot of people will bear down to be able to do a difficult exercise. So start checking for that. All right, so here's a shot taken of her when she's learning how to load. So she's doing a hard exhale and she is coming down too much with her external obliques. She's also got tightness in her back. So we're going to take a look at fixing that breathing pattern. So she's got a very poor breathing pattern here. And what's happening is that it's causing excessive back tension. She's having to overly work with her external obliques to fight for that, to get those ribs down. And she's bearing down on her pelvic floor, and that's causing bulging in her lower abdominals. Now, this is the same person. She's mid blowing up balloon here. This is max exhale. And you can see here how she's no longer bearing down. And she has a flatter lower stomach because she's not bearing down. All right, so you can see that lack of bulging. So she's mastered her deep breathing and core pressure regulation. The heavy feeling she had in her pelvic floor is completely gone, and her diastasis is healed. So she was a really fast patient of mine. She was great. She took on whatever I gave her, and she was like, okay, I can do it. I can feel it, which is such a blessing. Those are the best people to have that are so open to changing and feeling their body. Okay, so here's a side-by-side picture of her during a max exhale. So you can see here how inefficient her system is. So you can see her back is fighting the front of her ribs. All right, so we have all of this back tightness, so she's having to overwork to try to get her ribs down. And when that's happening, she's forcing too much pressure down. Here, she's getting her ribs down, she's got a great exhale, and you can see the lack of tension in her back so she's not having to fight from the front, and that's helping her get lots of lower TAs to help support that system. All right, so I've got 6 case studies in there on breathing. So you're going to get lots of video of people breathing and me doing a voiceover for you so that you can get an idea of what to look for in the person in front of you to make sure they get it right. All right, so just a quick little anatomy review. The two sides of the abdominal wall connect in the middle to form a line of fascia called the linea alba. Okay, we have 3 layers of lateral abdominals. We have our external obliques, we have our internal obliques, and then we have those deep TAs, which you can't see here, and they run pretty much like those internal oblique fibers at the bottom. So they're running straight horizontally, okay, through the whole system. The rectus muscle, the 6-pack that sits on the front, is encased in the rectus sheath from the aponeurosis of the 3 lateral abdominal muscles. This aponeurosis is what forms the linea alba. Okay, and that is why when you think about fixing someone's diastasis, you think about, okay, I need tension in those lateral abdominal muscles. I need to be able to create TA tension, those transverse abdominal specifically, because those are the deepest abdominal muscles. And that's what we're looking at creating tension to firm up the middle, because when we pull on the sides, it pulls the middle taut. All right, it's really kind of that simple. So you pull on the sides, it pulls the middle taut. Now what we're going to look at is the difference between closing the gap, so narrowing the gap, versus firming the gap. And that takes different muscles, okay? So it's pretty cool. So we're going to look at the difference between narrowing and firming and what those impacts are for our body. And just in case you don't know what aponeurosis is, it's a sheet of pearly white fibrous tissue that takes the place of a tendon in a sheet-like muscle. So think about it as it's kind of the tendon of the obliques coming in to form that fascial sheath, okay? All right, so hopefully that will be a little anatomy lesson to help you when you think about a diastasis in someone and what's going on. So can you heal a diastasis? That is the question of the hour, isn't it? The answer is maybe. It depends on how much fascia has been done. But you can always improve movement strategies. So no matter what, I think women need to improve movement strategies, even if they do end up having surgery because they have too much damage. But the thing is I've seen a lot of women heal. I've seen a lot of women where they could put their fist in their stomach. Their diastasis was so big and so deep they could put their fist in, and I've had them completely heal, like down to 1 finger width. I mean, it just blows my mind, the capability of the body to heal when it's in the right environment. Okay, so don't automatically think just because it's a larger diastasis that there's been too much fascial damage done. Don't discount the body's amazing ability to heal. So I really like to check a diastasis in all positions. So along with feeling their diastasis for width and depth when they're on their back, like a traditional checking, you're also looking for any doming of the rectus abdominals or bulging in the linea alba. So the one thing I've learned when working with people is that our bodies change strategies when we change input. So they might be able to lift their head and get some firmness in their diastasis when they're on their back, but when they flip over into a plank or they're doing some other intense exercise, they might have a wider gap or a lot more squishiness. Or vice versa, they might have some squishiness when they're on their back, but then we put them in a more intense position and that diastasis might firm right up, okay? So it pays to try different loads, different positions, and different things, and check women while they, and men, frankly, I've seen a lot of men with diastasis, and check them in these different positions to see how they are loading. All right, so we'll go into all of this, and we'll also go into doming and what to do to help that. So just keep in mind that the loading and compensation strategies change as demand changes. So don't automatically just write something off, and don't automatically assume something's safe just because they have some firmness on their back. So this is one of my biggest pet peeves when it comes to pelvic floor dysfunction is limiting exercise. So it really makes me mad when women are told they just need to stop doing whatever the exercise is that they love. They don't need to be told that. They need to be taught how to do it better. They need to be educated on the demands of the exercise and the strength they need to have to execute that exercise properly without harming their pelvic floor or their diastasis for that matter. So a lot of it just comes down to effort. We need to educate these women, and we need to let them know what they can do to get where they need to get. All right, so with guidance, we can really help a lot of women, and they can get back to doing whatever they want to do, whether that's running or CrossFit or yoga or whatever. So it's our job to help them become as strong as possible. So let's take a fun moment and talk about that diastasis pelvic floor connection, because I see it all over the internet, all over Facebook. There's all these celebrity trainers and they're like, yes, if you have a diastasis that's causing your pelvic floor issue. Well, not so fast. Okay, so if we look at some of the newer research on that, this was a study from 2017 that showed women with diastasis were not more likely to have weaker pelvic floor muscles or urinary incontinence or pelvic organ prolapse. So diastasis is not a cause of those things. So people really need to stop saying that. Okay, so in more cases than not, I actually have a lot of women that I've seen from popular diastasis programs where they've ended up with pelvic organ prolapse because they haven't learned how to regulate pressure in their core. They've just learned how to generate more of it to help close their diastasis, and then they ended up hurting their pelvic floor trying to close their gap. So I think this is a very, very, very important thing. And I always start women with pelvic floor education so that they are well versed at what's going on with their pelvic floor before we even start to think about closing that diastasis. Okay, so the study showed that at 6 weeks postpartum, 16% of women without a diastasis had pelvic organ prolapse versus only 4% in the group with diastasis. So my takeaway from this, and granted extrapolation from studies can be dangerous, but my dangerous extrapolation is could it be that those who reestablish intra-abdominal pressure before their pelvic floor had a chance to heal be at greater risk for POP? So could having a diastasis, because 100% of women have a diastasis when they go into the delivery room to have that baby. Okay, so if some diastasis after protects our pelvic floor from being overloaded, because pressure leaves the system through the weakest link. So if we jump back into things too fast and too soon and we increase pressure in the body and we don't have a diastasis like that, we were able to firm up that fascia and heal very quickly, does that put all of that pressure down on the pelvic floor and increase our risk of prolapse? Okay, so just a little food for thought. And that's what, when we go through this, we're really going to be thinking about things and thinking about the impact and thinking about the why behind it instead of just being like, oh yeah, that does that. Well, not so fast in a lot of these cases. It's a little more complex than that. Now, I do think there is an association that can be had with dysfunction within the body. So a couple things that we know. Women who are incontinent had greater synergistic rectus activation than women who are continent. All right, so women who tend to leak overuse the rectus abdominal muscles. We know the same holds true for external obliques. Women who tend to leak tend to overuse their external obliques. So stress urinary incontinence might be a symptom of our deep abdominal system coordinating with our pelvic floor. And that brings us back to correct breathing, correct posture, correct utilization of those abdominal muscles and our breathing system. So women with a diastasis have a deep inner core system that's not firing properly, right? Remember, it's those lateral abdominals and rectus and the tension that it places on that linea alba for that fascial connection to heal. So just a couple things to keep in mind. Diastasis and or pelvic floor issues are just signs that your body is not firing correctly on the inside. Okay, so we just need to get things working properly, and then it will help to fix all of the above. So we need to give women time to recover. In newly postpartum women, the rectus was thin and the cross-sectional area was wide. The rectus became thicker over time and the inner rectus distance decreased. Okay, so muscles need time to heal after getting stretched out. That's the bottom line from that. So a little bit of diastasis postpartum is completely normal, and we need to give it a little bit of time. All right, so this presents a great case for not jumping back into exercise that is too hard too soon. We have to give our abs time to heal. We have to give our pelvic floor time to heal, and we'll go over some great guidelines for that. But I just wanted to put that in your mind that the body really needs this time to heal properly, and jumping back into abdominal exercises that are too hard too soon postpartum could help to perpetuate that diastasis and prevent healing. So I still want to help it along with positive exercises, okay? So I still think getting things firing correctly really helps that diastasis to heal, but we want to make sure that we don't do too much too soon. Okay, one other thing we're going to talk about is myofascial slings. So I love making it all connect. Okay, so this brings us back to the isolation versus combining of muscle groups. All right, so functional training, if you wish. It's such a hot button word. All right, so should we isolate or should we make everything functional? Well, I think we should have a little of both. I believe in the kinetic chain. I've seen wild things happen. I've seen body parts that are way far away from the one causing pain or dysfunction to be the cause. So I think that we need to isolate in certain circumstances, and I also think we need to make it functional and combine in a lot of circumstances. So we're going to take a look at those myofascial slings and myofascial lines and go through some exercises to help lengthen the lines and help strengthen the lines and incorporate this into a full body recovery scenario and get everybody working together. So thanks so much for joining me. If you enjoyed this mini course, then I think you'll love the full course. So stay tuned for a quick preview from inside the course, and be sure to check out the syllabus to see all the areas we'll be covering. So in this mini course, I just touched on a couple slides from each area. I feel like I didn't even begin to scratch the surface. So if you were a little lost or a little confused about things, just know I will go into detail on all of these areas, and we will systematically cover it in a way that will make it easy to understand and break it down so it won't be so confusing. So lots of new studies, lots of new research. I wanted to make sure the course was up to date and that you were going to take away the most information possible. So I hope to see you in the course and get to know you better. I wanted to give you a quick tour just so you would know what to expect from the course and from the setup on the inside. So each week we'll have a PowerPoint lesson in it. All right, so this is week 6. It has 9 PowerPoint lessons in it. So you go through, as you complete a lesson, you can mark it as complete and it will automatically take you to the next lesson. Now, within each PowerPoint lesson, there is studies that we talk about in that particular PowerPoint lesson. And then in a lot of them, I have additional topics to further your knowledge on an area. So if you have an interest in, say, delivery, so if you're helping women that are worried about having a second and third child, maybe they're suffering from prolapse, maybe they don't want their issues to get worse. We go into that in week 5. So there's all kinds of additional topics of discussion that we go into to further your knowledge in an area if you're curious. So once you go through all the PowerPoint lessons, then it moves into additional explanations and tests, and not each week is the same. Some weeks have more additional explanations and tests and bonus sections, and some have more exercises depending on what the week looks like. But this is a super, super cool study that we included in here looking at the hip's role in pelvic floor dysfunction. I just love it. I love this material. I think it's amazing. And then you move into your exercise session where there are 7 lessons here. So you'll run through all of those, mark them as complete. And then that takes you to the end of week 6 where you will have a bonus interview with a professional in the field and we will talk about specific topics. All those questions are listed in the syllabus. So if you just run down the syllabus, I answer every single question directly that is on that syllabus. And then that takes you to the quiz. So the quiz is divided to make it easy. So if you need to go back, review answers, change things, you can do that. And so that takes you to the quiz. So each week you submit your quiz, and that way at the end you don't have some big giant test that you need to take. You get to take it as you go along, which I think makes it nice. This course has been absolutely incredible. I have really, really enjoyed being a part of learning and helping to change women's lives everywhere. And I hope to see you in the course so we can continue learning together.